Okay, we're going to get started with our first session. So, everyone, please think about who you want to keep talking with at lunch and at the breaks. For our first session, for our prevention level one, fostering coalitions and partnerships, I would like to introduce the chair of this session, Dr. Marcia Ori.
Thank you so much. We've talked about the 6 areas of prevention, and can you hear? Can y'all hear me? Okay, great. We've talked about the 6 areas of prevention, and we are absolutely thrilled to be first. We think partnerships and coalitions are so important. We've heard that already during the summit. And I think what we talk about today here on this first panel is going to inform all of our discussions. So what I'd like to do is just to start off introducing our panelists, and they are a terrific group of panelists. First of all, I'm Marcia Ori. I'm at Texas A&M. I'm affiliated with a Center for Community Health and Aging, which really already shows you the partnerships between community health and aging. And I'm going to be the moderator. So let me just go through first and introduce everyone. We have Dr. Janet White. She's a division director in heart disease and stroke prevention. And here we're going to be hearing about heart and all the risk factors for heart, but how this really also plays in for lessons learned with brain health. Then we're going to have Dr. Jennifer Carsons. She's at the University of Nevada in Reno, and she's been instrumental in Dementia Friendly Nevada, and she's going to be telling us about her initiatives. Then we're going to have Keena White, Dr. White. She's from the state of Mississippi, and she's been intimately involved in one of the BOLD public health programs, and we're going to hear about what's happening in Mississippi. Then we have Beth Zukowski, and she's with the ALZHEIMER'S Association with the South Carolina chapter. And she's going to be talking about the public health campaign they did, how it's so important to link brain health and heart health and other risk factors. And then finally, we're going to have Dr. Alan Stevens. He represents our health component. He's with Baylor Scott and White Health. That's one of the largest integrated health systems in Texas. And he's directing this Center for Applied Health Research, and he's expert in dementia caregiving. So we're going to be hearing about dementia caregiving and what we can learn about that in terms of prevention related to coalitions and partnerships. So let me just sort of talk again about why I think coalitions and partnerships are foundational to both public health and aging. And you can just see here 4 different examples. I think we're all familiar with the National Prevention Plan, and that's 10 years old, but it's still incredibly important. It's how we plan as a nation to increase the number of Americans who are healthy at every stage of life. And again, it takes partnerships for their 4 focal areas. Then we can think about CDC and its health in all policies. Again, the importance of looking at health in all sectors. And we can think now about dementia friendly America, and how it takes every single sector in society to add for quality of life and independence for those people who are living the lived experience with dementia. And then we can think internationally. I'm sure many of you are familiar with the WHO Healthy Decade of the Brain. Again, coalitions and partnerships are essential to their focal areas. So, what do we need to know about coalitions and partnerships, and what are we going to hear today? Here are just some highlights. It's sort of like a preview. One, I think what we'll hear is that coalitions and partnerships are so critical for both research and for practice. But if you think about coalitions and partnerships, they have many different purposes. So, one, you can think about your coalition and helping you identify the public health problem. You can think about the coalition in terms of helping you with recruitment, whether you're talking about programs or research. You can also think about implementation, evaluation, dissemination, and sustainability. All reasons why coalitions and partnerships are so critical. But there's a myth. We know how important the coalitions and partnerships are, but you can't just think anybody can create a successful coalition and partnership. The fact is, this just doesn't happen. You need nurturing, you need support, and really trust is the key. We've all had coalitions that have been successful, but we've all had bad experiences. And that's because there's really both a science and an art behind coalition and partnership building. It just doesn't happen. But the good news is that there are many community guidelines and toolkits where we build on the evidence, the experience that people have, so we can do this right. And let me just end by why I'm so thrilled to be part of this summit today. I think our major sponsors are really leading by example. That is, we have CDC that has its own set of coalitions and partners. And we have the Alzheimer's Association, which also has its own set of partnerships. And they're working together. So that's already one win. And working together to really address this issue of dementia risk reductions. And here's just one example of a toolkit. And we've talked about the importance of social determinants of health equity. And here's an example of CDC of one of its toolkits that develop partnerships and coalitions to advance health equity. So that's the introduction that I'd like to have. And now I would like to bring our very first speaker, Dr. Wright, over here.
Good morning, everyone. You can hear me. And thank you for that good morning. It is a pleasure to join here today. I'm honored to join. Thank you to our co-chairs, Drs. Giles and Mullen, both of whom are giants in this field. And Dr. Sherry, I appreciate your comments, and the fact that you're quoting hypertension stats from the podium means everything to me and to the effort. I think about it day and night. And then thank you to Dr. Owie in getting us organized. I'm a little intimidated because I believe that public health experts are master conveners. So for me to be sharing with you a perspective on partnerships and coalitions is, again, a little bit like I'm in the choir, I'm in your choir, but I will share with you some things that I've learned. And like many other speakers today, I'm going to start with roots. And let's just see, there we go. Nothing to disclose here except rabid about hypertension control. So these are my roots. This stern-looking guy is my dad, a primary care doc. The woman in the picture is my mother. She apparently perfected the smoky eye way back there in the 60s. The guy in the middle is my brother. And this event is memorialized as, you'll get a kick out of this. They were adding an extension to a hospital in Memphis. And this addition to the hospital cost $5.8 million. Can you imagine that you're adding a whole hospital extension or addition? But the deal here that the marketing person tried to capture is that my mom had been born in this hospital in Memphis. My dad, and then had gone to nursing school, graduated from nursing school there. My dad had interned in that hospital, and my brother was born there. My brother was going to wield a golden spade to turn over the first bit of dirt on the addition the following day. Interestingly, he's described, my brother, as being 3. My brother was 3 years and 2 weeks older than me. So I think this Peter Pan collar and the thing my mom has on indicates that somewhere 2 weeks after this picture was made, I was born. My purpose in showing this is to say my team, this is my team. My folks practiced primary care together for over 50 years in this little town of 3,200 people on the non-glamorous side of the Mississippi Delta, Arkansas side. And they were a team, they were a coalition, they were a partnership. And they were very important in my community. I now know that they were practicing in what we call a care desert and in an area of the country that has a high and disproportionate burden of chronic conditions. They didn't have data sources, John. They couldn't do surveillance. They didn't have quality measures, which was probably, I don't know, probably a good thing. So they didn't have any way to know about prevalence. It was high. Control rates, I'm sure it was low. And we know there were dramatic disparities. Healthcare and health were not the same on both sides of the tracks in my hometown, but they were dedicated to the community and pillars of it. So they sort of set a standard for me. I will also tell you that day and night, my work remains dedicated to these three people. Both of my parents had dementia. My dad had a rapidly progressive form and just disappeared on us. My mother had what more of you and I was familiar with, which is a very long, like 18-year course of Alzheimer's, where, as you know what happens, people just fade away from you. I will tell you one of her lasting connections. She was devoted to my dad and to my brother and eventually to me too. But the last connection she let go of was one to Bill Clinton. So she used to, even in assisted living, look over at a book that had his picture on it and go, "Oh, last night." So I don't know, but it's good to laugh, right? And so I want you to know this is why I am so supportive and so grateful for the work that all of you are doing to help fight this rotten disease. So let's talk about my trainers' experiences. I will just buzz through these, and I see I'm a little bit short on time already. These are things that I participated in and from which I drew a lot of lessons about how to contribute to and build coalitions and partnerships. I will focus, just fast forward onto Million Hearts, referenced earlier. So public-private partnership led by CMS and CDC to prevent heart attack and stroke. Many of the things I've learned, both to-dos and not to-dos, have come from that experience. Maybe I'll just I'll go to the top 10. The first I would recommend, and again, I know I'm talking to the choir, but I'll just share with you. By turning on a bright light, what I mean is try to articulate your goal in a way that it's obvious for everyone, ideally in a blink, so they get it from the get-go. Also, the bright part is to invest or to put into the hands and the mouths and the brains of leaders your goal so that they can take it to the top of the tree, whether it's in an organization or in a government agency. Let them pull that light up to the very top. When you meet with people to find out if they want to be in your coalition, they want to do this together, ask about their mission. Look for those areas of alignment, those where the Venn diagrams overlap, and learn from them what they care about, because that's going to create a lasting coalition. Open table, for me, in Million Hearts, there was no admission fee. In fact, we used to say, we don't want your money, we want your heart and soul. And so it's about the alignment of the mission. If there is a pay-to-play mechanism, let people know early on what the cost of sitting at the table is. Gather regularly. You want to set a cadence for your partnership so that you come together, you start to establish the relationships. Even if no one shows up in the beginning, you still hold the meetings so that, again, they know you're there. And make sure that you pass the mic each time so that you're not preaching, but you're actually learning from everyone around that table. I recommend going as light as you can go with the rules. Don't create obstacles to sitting at the table. Again, there may be rules around use of a logo or You need to find an MOU. You need to sign an MOU if there's money involved. But try as much as you can to keep the bureaucracy of being in a partnership as light as possible. Next one. My own bias is that if you are part of the team that's organizing the coalition or the partnership, do as much of the work in advance for the group as possible. Again, lowering the activation energy so that people can join and find their work in the coalition as opposed to having to do a lot of pre-work themselves. Again, thinking about making it easier for folks to join. This one, if you have the firepower in your organizing crew to collect data on progress on whatever metrics you choose and track and report, we tried that in the early years of Million Hearts, but it's really hard to do that work. It's very important. We all want to show results, but if you're a small and a nimble organization, I recommend a policy of bring your own metrics, meaning everybody who comes, you define your definition of success and you monitor your own progress. You can report it out to the coalition, but if you need to get started with the work, I would recommend again, if you can hire people to monitor, report, collate, do all that stuff, great. That's wonderful. I just haven't belonged to coalitions and partnerships where we had the luxury of a whole lot of staff to do that. You can still monitor progress by asking each organization or partner to monitor their own success. Act early and often. So again, this is about momentum building. Try to spend as little time as possible organizing and get started. Get started somewhere so that you start to generate the enthusiasm and the success, even if they're small successes. And then moving on about small successes, figure out what is most meaningful to your partners and make sure that you celebrate everything along the way. Dan mentioned celebrating. Where are you, Dan? So brilliant. So important. Life is short. So in your coalition and partnership, making sure that you recognize the contributions of all. And I think in Million Hearts, what we try to do is always attribute the success to the people that were involved, not to the initiative, because the initiative is made up of those partners. And then remember always, there will be friction. Coalitions and partnerships, just like families, there's friction. And so try just to always go back to what your primary mission is, because as the organizers or supporters of the partnership, the mission is your mission. I think that's it for me. Thank you so much.
Thank you so much. That was an excellent set of 10 lessons to avoid road rash. Let's have our next speaker come up, and let me set the slide for you. Perfect. Dr. Jennifer Carson.
Thank you. Thank you. So I really appreciated Dr. Ori's comment about the importance of trust in the work of coalitions and partnerships. I think that trust and authenticity and vulnerability are important qualities for any coalition leader or facilitator. And so in the spirit of cultivating some authenticity and vulnerability, let me tell you that sitting here is a little outside of my comfort zone. But I'm really excited to be here because I believe in this work. I believe in the importance of what we're doing. And I'm so incredibly grateful to be part of this amazing panel and to be part of the summit. So thank you so much for the opportunity to be here. I usually say it takes me at least 10 minutes before I get my stage legs. And so I think the last 2 minutes of my talk might be really, really good. But good morning. So my name is Jennifer Carson. I'm director of the Dementia Engagement Education and Research Program in the School of Public Health at the University of Nevada, Reno. The DEAR program aims to build capacity within individuals, organizations, and communities to support living well with dementia. And we are proud to serve as the administrative home of the Dementia Friendly Nevada effort. We also partner on Nevada's BOLD public health program, and this is a valued relationship that I will tell you more about in this brief overview of Dementia Friendly Nevada, promoting risk reduction and improving the culture of dementia through community coalitions and authentic partnerships. So this morning, I'll briefly describe Nevada's BOLD dementia-friendly infrastructure. And then I'll encourage us to consider possible ways to mobilize high-impact collaborative action, sharing examples from Dementia-Friendly Nevada. And then I will share 3 examples of risk reduction or brain health promotion opportunities developed by members of Dementia-Friendly Nevada. But first, let me just provide a little context. The Nevada Department of Health and Human Services includes the Division of Public and Behavioral Health and the Aging and Disability Services Division, or ADSD and DPBH. And then ADSD is our state unit on aging, so we just have the one. In 2013, the Nevada Task Force on Alzheimer's Disease was created within the Department of Health and Human Services. The task force is responsible for developing our state plan to address Alzheimer's, and I'm proud to serve as a member of this task force. In 2016, our State Unit on Aging, ADSD, brought the Aging Services Network together to envision a new initiative that would help us promote communities that are more respectful, educated, supportive, and inclusive of people who are living with dementia and care partners. ADSD submitted a successful grant proposal to the Administration for Community Living to launch Dementia Friendly Nevada, and I was invited to serve as a program director of this initiative. During the 3-year funding period, we launched our first 6 coalitions representing tribal, rural, and urban communities. Each coalition was and continues to be led by local co-facilitators who work to ensure diverse representation at the table, including people living with dementia and care partners. Each coalition works collaboratively to identify their own goals and actions for community-driven change. And during the ACL grant, our first 6 coalitions achieved significant outcomes. In 2021, then, the Division of Public and Behavioral Health applied for and received CDC BOLD funding to address dementia from a public health perspective. And 3 of my partners from the Nevada Division of Public and Behavioral Health are here with me today, Seth, Sarah, and Sarah. If y'all don't mind just waving, that way if people have questions and want to learn more, please do track any of us down, because this is very much our story. This is reflective of our work. So specifically, our goals on that CDC BOLD funding include growing the Dementia Friendly Nevada by welcoming 5 more coalitions, and then leveraging the robust infrastructure we've developed to improve the culture of dementia while also promoting brain health and risk reduction at the local and state levels. We've also worked to align the Nevada state plan with the CDC Healthy Brain Initiative roadmap. And through this infrastructure, Dementia Friendly Nevada is able to foster solidarity and collective action at the state level while honoring diverse communities and collective action at the local level. To help us work in the same clear strategic direction, members of Dementia Friendly Nevada developed their own values and a unified strategic direction. In 2016, at the onset of Dementia Friendly Nevada, members of the Aging Services Network worked with ADST to develop our mission statement seen here. Then in 2017, members of our first 4 coalitions developed a set of shared values. We call these values our mobilizing beliefs, and they serve as an ethical roadmap for coalition decision-making. Then in 2022, we convened a 2-day strategic planning summit with representatives from our then 7 coalitions. This summit was guided by a strengths-based appreciative inquiry, a strengths-based participatory action research methodology called appreciative inquiry. Nearly 100 members engaged in the appreciative inquiry process to develop 5 aspirations and corresponding aspiration statements that can lead Nevada toward a better future. These dementia-friendly aspirations and state plan recommendations are currently being advanced at the local and statewide levels. Specifically, each coalition is working this year to advance 2 community-driven goals related to a recommendation and an aspiration of their own choosing. In addition, we have 2 statewide work groups that are also working on goals related to the state plan and dementia-friendly aspirations. We also host a quarterly statewide meeting via Zoom, and this meeting is open to all 500 plus members of Dementia Friendly Nevada. This quarterly meeting is where we connect the dots, cross-pollinate ideas, discuss and solve problems together, share resources, build relationships, and celebrate our individual and collective successes. So now that I've provided an overview of Nevada's bold dementia-friendly infrastructure, I'd like to share a bit about the approaches we use to genuinely partner. First, each coalition follows the Dementia Friendly America process to facilitate and mobilize community-driven change. But in Nevada, this process is further guided by the principles and practices of participatory action research. Each phase of the Dementia Friendly America process is an opportunity for the iterative cycles of PAR as we plan, act, observe, and reflect together before moving on to the next phase. Further, the Dementia Friendly Nevada support team works to uphold a certain quality criteria for our participatory work. In short, we aim to promote equal access by conducting research, or in this case, strategic planning, with rather than on or for people. To enhance awareness of one's own views and opinions and those of others, we engage in regular critical reflection and dialogue, and we work to draw upon a wide range of knowing. To encourage action, we address questions that are of immediate significance to our community partners. And finally, to enable action, we work to leave lasting capacity amongst all those involved. Furthermore, we are committed to a nothing about us without us approach to community-driven change. We aim to actively incorporate and value diverse perspectives in decision-making, most importantly, people living with dementia and care partners. To help us avoid tokenism, we adapted a set of questions based on the Authentic Partnerships framework seen here, and our coalitions and work groups use these questions to reflect on the quality of our partnerships. And we have found that what helps support the genuine engagement of people living with dementia is generally what helps to support everyone's engagement. Authentic partnerships promote Authentic partnerships promote empowerment and equality and build collective capacity for shared decision-making and social change. The final approach I'd like to share with you is what I'll just call dementia-friendly engagement. By focusing on the inclusion of people who are living with dementia and ways to support their amazing contributions, we have discovered approaches to coalition work that are more accessible, more meaningful, more practical, and honestly, just more fun for everyone involved. I believe that any public health coalition should be an inclusive and accessible space for all community members, including people living with cognitive changes. Now I'd like to provide 3 very brief examples of the risk reduction and brain health promotion opportunities developed by members of Dementia Friendly Nevada. The Healthy Brain Initiative Roadmap for Indian Country highlights the great work of the Pyramid Lake Paiute Tribe's Dementia Friendly Coalition, Pija Tsunami. After the roadmap was released, Pija Tsunami used it as a framework to plan the first Nevada Tribal Summit on Brain Health and Dementia in 2019, providing education and convening important conversations about risk reduction among 114 participants from 14 different tribes. They hosted their second Tribal Summit on Brain Health and Dementia just last month. Last year, following the lead of Pija Tsunami, dementia-friendly Douglas County hosted their own summit on brain health and dementia, but this time using the Cleveland Clinic 6 Pillars of Brain Health as an organizing framework for education and engagement. 82 community members spent the entire day at the Carson Valley Inn Casino. but not gambling and hitting the buffet. Instead, it was amazing. They spent the entire day engaged in brain health education and enjoying a heart healthy, brain healthy lunch. They also learned how to use the Cleveland Clinic's online Brain Health Index to identify opportunities for better brain health promotion. And my last example is our new hot off the press Dementia Self-Management Guidebook, developed in partnership with 6 advisors who are living with dementia, using participatory action research and human-centered design. Our advisors, seen here, want the world to know that it is never too late to promote brain health. Never. This resource specifically designed and formatted for people who are living with dementia. Each module provides current information about brain health and dementia and aims to assist people in developing personalized strategies for living well. This is an open access resource. We hope that you will use it in your efforts, and it will soon be available for free download on the DEAR program's website, and the QR code is there. In closing, I'd like to borrow from the wisdom of philosopher and social theorist Paulo Freire, who said any situation in which some people prevent others from engaging in the process of inquiry or change is one of violence. To alienate people from their own decision making is to change them into objects. I share this conviction and believe that it applies across the board in all situations, and most certainly to the work of coalitions. Partners should never be treated as objects or as passive recipients of benevolent but paternalistic change strategies or interventions. In successful coalitions, partners are active citizens. Partners are decision makers. Through authentic partnerships and collaborative action, we can develop a greater consciousness of the conditions in which we find ourselves, and with a range of meanings instead of a single authoritative interpretation, address the question, where do we go from here? Thank you very much for this opportunity to share, and thank you so much to my partners in Nevada who make this work possible.
Thank you very much. I really loved the sort of first hand-on experience of going from goals to actually action. And I love that term, authentic partnerships. So thank you so much. We're going to go to our next speaker. This is Dr. White. Thank you so much from Mississippi.
Absolutely. So, Jennifer, that's a really hard act to follow. But greetings from Mississippi. I do have a couple of colleagues in the room that I want to shout out. Cassandra, our interim director for preventive health, is here, and then my healthy aging team is here. Lakika and Sandra, wave your hand from Mississippi. So the work we do is not for the faint of heart. I think if we were to say, name one thing that you can think of if you hear the word Mississippi, it's probably not very positive. But the work we do for Alzheimer's disease and related dementias is amazing. We have really pulled together some amazing partners and coalitions. And I often say with our BOLD work, so much happened before we received the funding that we had an amazing foundation of soil that was so rich and ripe. And the BOLD program just really added and fertilized what was already there. So I'll share some highlights today. And then Jennifer, I'll point out, as of last week, Mississippi has joined the Dementia Friendly America Network. So we will follow your lead in doing a lot of this great work. But we were a state that was awarded as a part of the initial cohort for BOLD. And although we all share the same priorities, one area of emphasis for Mississippi was really paying attention to rural areas. Our state is very rural. And if you've lived or worked in a rural state, you understand that what happens in the urban community may not be as replicable in your rural communities. And so you really have to treat that a little bit different with our work. And so for the BOLD program, we spent a lot of intentionality working on how does this work in both our larger communities, but also our smaller communities, where social determinants of health and health disparities are a real issue. So I'll share some of that success along the way. But support for caregivers was also something that we highlighted as a part of our priority. We do have a legislatively mandated family caregiver coalition, so we were able to tap into some resources, but I'll highlight some of the things that we've done to really support our caregivers. So here's the bad news about Mississippi. Disease mortality. Mississippi has the highest age adjusted mortality rate for Alzheimer's disease. Folks are really surprised to hear that. And the bigger issue is our workforce shortages. We have less than 30 geriatricians in our state. That is a challenge, which means we do not have enough individuals in place to support this growing need to address Alzheimer's disease. So we have to look at fostering partnerships. We have to look at our primary care providers. We have to look at our neurologists. We have to look at a number of people who have to step up and help address this burden and this issue. We have a number of unpaid caregivers in our state, many who do not identify as a caregiver. They identify as just someone taking care of a loved one. And so we have to make sure that we prioritize what they need for both informal and formal caregiving. And so we understand the disparities in our state, but there are so many positives, and looking at how we tap into our partnerships is a huge way that we've been able to build success. So we do have a very robust state plan structure in our state. We have 5 goal groups that focus on how we address Alzheimer's disease in our state. These 5 groups include brain health, community awareness, coordinated care, research, and caregiver support. We have a leader and a co-leader for each of these goal groups. And prior to the BOLD program, there were around 40 individuals really focused on this work. Embarrassingly enough, public health was not really at the table. We supported the coalition with a Healthy Brain Initiative project that we had. Our cardiovascular team was at the table, but it wasn't a true commitment. It was more so an opportunity to collaborate, but there was no long-term sustainability. And so when we received the BOLD program, we had 2 choices. We could either start a new coalition, and sometimes individuals like to be the first and the founder of things, but what we recognize is the synergy of collaborating with a foundation that already existed. So we joined the existing coalition, and we're so proud to say now we have over 65 volunteers doing this work. And our cardiovascular state public health director has recently joined the coalition again. So we're really excited to welcome that team back, because we know in order to really foster this work, we have to have that presence. Something else we wanted to do was prioritizing health equity. When we think about the work that we're doing and the disparities that we're addressing, health equity should not be ad hoc. It should not be something on the side. It should really be integrated. And so we developed something called Health Equity Ambassadors. For each of those 5 goal groups, we have a trained volunteer who understands cultural competency, implicit biases, and we've also trained them on social determinants of health to really educate them on, when you're meeting and you're strategic planning, do you really understand access to care? Do you really understand health literacy? Do you really understand the impact of education and how that affects whether or not individuals understand medication management, how to get to an appointment, how to address and look at the warning signs of cognitive impairment? And so we're promoting these health equity ambassadors as champions for change within our state plan. And so we're excited to work with them throughout this effort so that we can really address these health disparities. Mississippi has one of the largest African American populations in the country. When you think about the disparities associated with Alzheimer's disease, what does that mean for our state? We have to take a collective approach to addressing this issue, and these are some of the small ways that we're trying to do that. So I love this snapshot. Some of you may not be able to see it quite well, but these are all the key stakeholders in our state doing this work. So in Mississippi, our state public health agency is separate from our Department of Human Services. In some states, it's the same. In ours, it's separate. But we also have our state Department of Mental Health doing a lot of this work, and also our state Alzheimer's Association chapter. When the BOLD program was introduced in our state, we really wanted to make sure that we were not taking credit for the brilliance that already existed, but really leveraging what public health could bring to the table. Public health brings essential services, we bring data to action, we bring workforce capacity, and we bring that connecting convener space. And so if you look at all of the different entities at the table, we really do an excellent job of making sure we maintain that trust. During the COVID pandemic, I want to say that many public health entities struggled with trust. If we shared data, was it accurate? Was it manipulation to elevate the need that we have? And in this space, we really recognized that we had to maintain trust with our partners. When a lot of our long term care facilities closed, that was a challenge in the Alzheimer's disease space because we understood that social isolation would be a huge issue. And so, as a coalition, we had to work with our long-term care facilities and really identify ways that we can engage with those individuals. And so this web of partners are individuals that are fully committed in Mississippi to doing this work. And it's not easy. There are resources that are very limited. The commitment is challenging because we understand there are other priorities, but on a daily and weekly basis, we really fight to prioritize that Alzheimer's disease is just as relevant of a chronic disease as heart disease, as diabetes, and as cancer. And that's an ongoing challenge. But we are committed to making sure that we prioritize that. And with these stakeholders highlighted, I think we'll have a great shot at continuing this. Along the way with our BOLD program, we established new partnerships that I'm so excited to see some of them in the room. Many of us are Zoom drained. So for the last 3 years, we've only met via Zoom. But to see so many friends in the audience is wonderful. Our BOLD Centers of Excellence, our state has worked with all of them, from early detection to risk reduction to dementia caregiving. We've established these partnerships and they're extremely meaningful for us. They're not just something to put on paper. We actually take the expertise and implement that within our work. Even with our HBI components, Us Against Alzheimer's is here. Daphne and the team with Dr. Monroe, we have worked diligently to utilize the NADEX system that they have and looking at our local issues within our African American and Latino communities and really understanding where we can use that data to address our priorities. We actually have our state BRFSS coordinator providing trending analyses in our state now. So for the last probably 6 or so years, every odd year we implement the subjective cognitive decline module. We actually have our state coordinator coming to our strategic planning meetings and sharing that data so that we can inform our state plan. Our Family Caregiver Coalition has been phenomenal. And in Mississippi, we also have established an age-friendly public health system. So we now work with our regional health systems director with the Alzheimer's Association, who is establishing age-friendly health systems across our state. So we have so many ways that we're trying to leverage this work, and I highly encourage many of you to think outside the box. You would be surprised the number of individuals that are interested in addressing Alzheimer's disease. And even if you're not talking about Alzheimer's, brain health. We have learned in certain rooms, you cannot lead with Alzheimer's disease and dementia. You have to lead with the term brain health and back into it. And so that's something we've taken away. We've also worked with our chronic disease coalitions, our health systems, and Mississippi is proud to say that in 2023, our only federally recognized tribe is now a part of our network and actually serve on our coalition. So these are some of the things that we've done over the last 3 years with the BOLD program. We've hosted caregiver conferences with our association. We initially started doing Purple Sunday initiatives in our faith communities, but we are now partnered with Alter Dementia and working diligently with Dr. Epps and her team. We've hosted continuing education webinars and reached hundreds of nurses and social workers and providers, educating them on the different assets of risk reduction, primary prevention along the life course. Continuing medical education, we're working with our clinical providers and educating them on billing and how we can really integrate this work across the primary care space. We have Mind Minute newsletters that we send out quarterly to clinical providers. We've hosted the Brain Health Inequity Symposium. We're now in our 3rd year of hosting that, which is really exciting to talk about disparities and inequities in our state. Again, I mentioned our ambassadors. Someone earlier mentioned something that we did in Mississippi, which is our Healthy Brain Initiative alignment. We took the roadmap and aligned it to our state plan to know whether or not we were actually meeting those roadmap actions. And those are some of the other things, but takeaway for me is best practices. Promote healthy aging and the reduction of risk factors as a shared priority. It's not in isolation. When you treat the whole person, it's a lot easier to address disparities in disease. Look at your linkages, talk about your plan, whenever you can, and make sure that your risk reduction messages are customizable to diverse communities. The same message does not apply to all. You have to be more diverse in how you're sharing that information. And then high value engagement is so important. We can't just have you in the room. We have to show value and make sure that their mission is your mission and you are respecting their space. And informal collaborators are just as valuable to the conversation. Thank you.
Thank you so much. That was an excellent example of how a bold initiative working with all kinds of partners can build collective impact. And what I really loved is it can be done in a rural state and also your attention to health equity. So thank you so much. So our next speaker is going to be, I'm going to try to get the name right this time, Beth Solkowski. Perfect. And from South Carolina, take it away.
Thank you so much. It's exciting to have people attempt to say my name. Usually people are just like, Beth. Yes, that's me. That's fine. I go by Beth. It's totally fine. I'm excited to be among these panelists, and honestly, listening to the work that you're doing, I'm just like, wow, there's so much more that we could be doing. But the point is, and what I hope you take away from my part of this, is you have to start somewhere. And so if you aren't already working on all of these robust strategies, sort of how do you find a beginning point? And so in South Carolina, we have been really lucky to establish a really great relationship with our State Department of Health and Environmental Control, which I will now refer to as DHEC. So this is our public health entity for the state. And back in the days, I've been with the chapter 16 years, our conversations really started when we had a little bit of money in our pocket and we went and said, ooh, we'd like some Griffiths modules, please, and started collecting that data on subjective cognitive decline. That opened the door to meet more people at the agency and to have conversations with leadership to make the case for the value of dementia risk reduction as well as early intervention in our state. And really luckily for us, we didn't have to make the argument too hard. It is pretty clear from pretty much any map. We're a lot like Mississippi. Any map you look at, we're in the place where you probably don't want to be. Our health is not great. We aren't known for that. We're right in the stroke belt. This is an older map, but at the time that we started this relationship, we had significantly higher risk of both stroke and cardiovascular disease, as well as greater than average rates of obesity, high blood pressure, and cigarette smoking. And so when we sat down and we had that conversation, the agency said, oh, well, yeah, we totally understand and we get it and we're on board, but we just don't have the capacity to start some kind of new initiative. But at least we had started that conversation. And in 2016, an opportunity arose through the Alzheimer's Association nationally, as well as the Association of State and Territorial Health Officials. It was a small grant. It wasn't a lot of money, but it was a grant. And we brought it to our friends at DHEC and said, hey, what do you think? And they said, well, it's not a lot of money, but we could probably do something with it. And so they applied for it and received funds to implement at that time, the iteration of the Healthy Brain Initiative roadmap. We were really looking to educate diverse audiences about risk reduction, but in particular, we tried to focus on integrating those risk reduction messages for dementia into existing public health messages, as well as to reinforce those existing public health messages, really looking for ways that these messages would align. And I will say, being a partner, we had a stakeholder group at the Alzheimer's Association really worked hand in hand super closely because this was a priority for us as well. Everything wasn't all flowers, roses and sunshine. We had to go through a little trial and error to figure out how we can make the maximum impact. At first, we thought, well, we'll do these community education programs and we'll teach them about empowering people for their own brain health. And from that, people are going to say, hey, we want you to present at our church. Hey, we want you to present in our community. Hey, I want to volunteer to teach this. And as you know, that was sort of a little bit naive to think that we were just going to generate these numbers out of the blue. And so after spending a lot of time on this approach, we said, you know what, this just isn't, it's well received, but it's not the impact that we know we need to make to change the course for risk reduction in our state. So we really went all in on a public awareness campaign, which was multifaceted. And essentially what we did is we took that data that Dr. Correa presented this morning on where the evidence is really strong, where it's moderate. We determined the messages that our public health agency felt were strong enough for us to communicate, and we put them together. We circled, we crossed out, we got our content together. I put it together in a brochure. We ran it up the chain of command in DHEC, and through the brochure, through a website on DHEC's website, as well as a brain health pledge. I'll tell you a little bit more about social media messaging with several stakeholder partners, earned media, and radio PSAs. We really felt like we were making the impact that we wanted to, with the core message of what's good for your heart is good for your brain. Again, sticking to those messages that were already being delivered through chronic disease management and risk reduction more generally. So another component of this really tried to incentivize people to commit to healthy behaviors. So for a series of months, beginning with June, which is Alzheimer's and Brain Awareness Month, a great opportunity to bring this conversation to the table, we did a series of monthly drawings for people who participated in an online pledge that basically had people say, yes, I am going to work at exercising more frequently, eating more healthfully, taking risk reduction measures such as wearing a helmet or a seatbelt to minimize the risk of brain injury. And so that was an additional way that we're able to get the word out, not only through DHEC, but through, Alzheimer's Association, our publications, through social media of all of our other stakeholder partners. And DHEC took that message and really extended the reach as much as possible through some paid PSAs on local radio stations. This was a really important component because each station chose a speaker who would be culturally appropriate for delivering the message to that audience. This let us reach more rural communities as well. And the script referred people to both the DHEC Brain Health webpage and a high priority additional public health message, which was that smoking quit line, and really driving home that message. So through the radio PSA campaign, we really felt like we were reaching more the mass that we were trying to get to, including those rural and diverse populations. So that on top of the print materials, the pledge that we did, and our shared cross-posted social media, we were pleased with the results that we got in our reach. So this, if you saw back on one of the early slides, this started in 2016. This is 2016 and 2017. So a few years ago now. It's not something that dollars are currently going into, but it's something that we're keeping alive. DHEC still has this brain health website active and is updating it as new materials come out. They're continuing to reference these resources and their relevant press releases. We'll be referring to this in some Dear Colleague letters that are going out through physician organizations here soon. And it's really relevant also right now because we have just updated our state Alzheimer's plan for the first time in 14 years, thanks in part to initiatives as a BOLD funding recipient now. And I would say that our early work on this public awareness campaign helped develop the trust and the buy-in for us to really work together as partners. And that continues to this day. And these assets, I do want to add, are shareable. I'm happy to share them with you if you'd like to get a hold of them to consider if it can be something that would be useful so you don't have to start from scratch. It's always nice when you don't have to reinvent the wheel. So, of course, there were challenges, right? Money is always an issue. Our initial grant period ended, so we're not going at quite the same clip that we were at that point in time. Our DHEC also, their funding period ended for our division on healthy aging. So that kind of changed the staffing situation, who would be the key point when it came to brain health. And we also discovered through our process that while we felt good about the reach that we had, we knew from the get go that we didn't have the budget to develop separate culturally appropriate messaging for Spanish language speakers. And that was something that we definitely felt like we had a missed opportunity and a future opportunity to work on in our state that has a large Spanish speaking population. But what I'd like to really underscore is you have to start somewhere. And with teamwork, even if you just have a shoestring budget, you can make something happen and start building that relationship. In our case, we developed assets that can easily be updated and redeployed and built upon. So that's something, even if it's not going at the same clip that we were in 2017, it's something we can easily pick back up, make sure it's current, and get back out there into the field. And importantly, this is a partnership that has weather changes both in funding and in staffing. I mentioned staffing changes on the DHEC side. My role has changed. I focus primarily on communications, but our state government affairs staff person for the Alzheimer's Association now owns this relationship and works super closely with DHEC in our current bold funded period, as well as on that Alzheimer's state plan, which will be entering implementation and will require those partnerships again to take these recommendations and move them forward. And so, in terms of sustainability, this created the drive to work on that, to continue to seek resources, even if we didn't have a flush budget at the state level, and to continue to look for opportunities to make this a more permanent fixture in our public health agency to kind of develop our ambitions down the road. But one thing I can say absolutely for sure is that Alzheimer's Association has a local chapter in every state in the country. And so you do have allies that are close at hand, as well as other health organizations. In South Carolina, we worked with American Heart Association, as well as Eat Smart Move More, because our missions naturally aligned. And someone earlier said the word alignment. I think that's really key here because we're working with such limited resources and limited time. Your maximum payoff is going to be where you can look to see where your work naturally aligns, because that helps everyone share equally in the buy-in and the drive to get this message out there. You can find this and other case studies in the current iteration of the Healthy Brain Initiative Public Health Roadmap. And of course, I will be here during the day. Here's my email address if you'd like to learn more about any of this or look at any of the assets that we developed. We're very happy to share. Thank you.
Thank you so much. I think we've learned how important public health messages are, but they can be much more successful with coalitions, and they really take continual innovation over time. And I think that's the point about interventions. You don't just stop at the beginning, you keep working and innovating. So thank you so much. Let's have our very last speaker come up. It's Dr. Alan Stevens.
Thank you, and let me start with my congratulations to the previous speakers who all present such thoughtful and best practice-based programs, which are very impressive. And I'm also going to represent a switch from that that model that you all demonstrated so beautifully. I think Dr. Ori may have mentioned earlier, my primary area in the field of aging has been in the field of caregiving, especially dementia caregiving. And so I'm not particularly known as a prevention researcher. I'm a research psychologist by training and tend to be more on the intervention side of dealing with the consequences associated with dementia and dementia caregiving. So with that, let me say, but I do believe that when we think about dementia now and as it impacts our lives and more it impacts almost all of our families, we have to think about how multifaceted dementia is and how it impacts so many people either from a caregiving perspective or those living with dementia. And the more we broaden, I think our definition of prevention from primary prevention to also include secondary and tertiary prevention of the negative consequences of the disease, reducing low value health care for the person with dementia who can just make things worse for everyone, is also a bigger, kind of a bigger tent that I'm going to present a little bit of today. But certainly, no doubt, we must keep our eye on primary prevention and double down on that, especially in the aspects of research, which I will touch upon. So the other difference in my presentation is that I'm a very practical kind of guy, and you're going to hear some very practical things. I hope you will find practical because, as we say in Texas, sometimes you just have to hitch your wagon to somebody else's wagon because you don't have the money or you don't have the innovation or the motivation to develop the programs that we heard about earlier, but you still can do something. And you can still work in your community to find ways to do that. So I'm going to hit on a couple different topics, which I think would be practical ways for all of us to engage our communities in prevention research with activities that are already ongoing. In the area of family caregiving, many of you may have seen last fall, it was our first national strategy to support family caregivers. And it was delivered to Congress, and we were very happy to see that parts of that national strategy ended up in the Biden administration executive order a couple weeks ago. Sarah Locke is back there cheering, so everybody cheer for AARP who helped get this act passed. They were instrumental in getting this passed way back years ago and have been very loyal to its implementation. So we have we have a national strategy now that's important, and hopefully you have seen it and know more about it. And I was fortunate enough to serve on the appointed committee that helped create the strategy and the supporting documents. And I also want to acknowledge that Dr. Lisa McGuire and Dr. John Omara was very supportive and very helpful in the support of the creation of the document and representing CDC. So thank you all. So the national strategy has 5 areas for action. I'll focus on the first one because it's awareness and outreach, which aligns so well with public health. But more importantly, I want to point out that the national strategy, a corresponding document, is the list of federal actions. There's over 350 federal actions that federal agencies have committed to. Now, again, these are largely around supporting family caregivers, but you can find a way to talk about prevention because nothing is more motivating than personal experience. And the caregiving stories that are so much more important to this document than any contribution that me or John or Lisa have made were made by the caregivers who participated in telling their stories and providing important content to the supplemental documents, and their stories are available online. Please go if you haven't and listen at some of these comments and these videos, because you will hear not only people talking about the burden of providing care, you will hear people talk about the fear of their own health. And if they lose their health, what happens to the person they're caring for? And I'm not just talking about dementia. This is a broad swipe of caregivers, parents of adult children with disabilities. maybe some of the most compassionate and some of the most worrisome stories you hear are from those individuals too. So prevention, caregivers are a point of prevention in which they are extremely motivated and they need our attention. Keeping in line with caregivers being motivated, caregivers and I think the general public increasingly becoming motivated to participate in research. And one of the largest, in fact, it's the NIH's largest ever funded trial, is called the All of Us Research Program. It is a precision medicine research program that, with the goal of enrolling 1 million people by 2026. We're about halfway there, slightly over 500,000 now, and we are on track to do that. I serve as a PI of the local site in Texas. This research brings together not only genomic information, which we know to be important, but probably doesn't tell us the whole story, right? Or we'd probably have a disease, we'd probably have a cure by now. Environmental factors, where you live, your health care, because people submit their electronic health records, and they complete self-report questionnaires over a length of, at least if you're joined early on, it's been going on for 5 years. We just celebrated the 5-year anniversary. It'll go on for at least another 5. So we'll have all of these very different important pieces of data that is curated into a single data set. It's a big contribution that will inform a lot of information, a lot of things about chronic disease. But I think we'll especially see very interesting research come out around dementia. So I'm going to go quickly here because there's a lot in it for folks to participate. But you may ask, why am I telling you about this? In the fall of 2022, we were lucky enough to be a part of the sponsor of the local Alzheimer's walk in Bell County. And we had both of my research programs set up with tents, with one being the dementia care tent on the right here, and on the left, the All of Us tent. So in the dementia care program, we were promoting 3 different caregiving programs. Which topic do you think got the most attention? The All of Us program, 10 to 1. We got 30 cards for people interested in being a part of the All of Us program. 3 people signed up to be part of a caregiving program. Tides turn, people focus on different things. Your audience is so important. These are family members, these are friends of individuals with dementia. They've seen the lived experience and they want to help. They want to do something about it. So again, very easy to be to join and to be a part of this. Share this with your colleagues and with your constituents. You can join online. It's a national study. If you live in a zip code in which there is a enrollment site, you can make an appointment to go into the enrollment site and do what we call PM&B, physical measurements and biospecimens. If you do not live in an enrollment area, the NIH will send you a saliva kit, kind of like 23andMe kind of thing. They'll send you a saliva kit, and you can participate that way too. So consider this as a way of, again, and I want to say an easy way, a way that we can all start thinking about prevention, of providing additional data that can support prevention. Lastly, I want to talk a little bit about my experience of being a researcher in a healthcare system where I've been able to learn a lot about the delivery system. I'm not a physician, clearly, PhD, but to understand how care systems and healthcare systems are working today is becoming increasingly challenging to know in respect to what we were talking about today of how do you partner with a healthcare system. Many of you may have been frustrated by this experience already. Who do you talk to? Who makes decisions? Where's their emphasis? What are they willing to spend money on? I get questions like that all the time from my community friends of, how can I get in the system? How can I get a foot in the door? And usually I don't have a really simple answer. But what I can say is this: primary care providers in particular increasingly focused on the topic of dementia, both from dementia care. We've done several large trials in our system. To tell you, not to brag, but just kind of to tell you how interested, since the beginning of COVID to about 6 months ago, we enrolled 1,000 persons living with dementia and their family caregivers within our Central Texas region, which is not a huge population, but that's how interested, all through primary care, that's how interested primary care docs are in getting the message out and helping people get services. Equally important is around what do they tell their families regarding prevention. Healthcare systems, when you can start to work with them and talk with them, find out if there's any financial incentives for them to provide health and wellness activities. This is particularly the case if they have either a health plan or an accountable care organization where they are at risk for some of the healthcare costs for the person. So again, this gets really boring and really detailed, but it's what's going to drive your partnerships with these healthcare systems, because I'm going to go back to kind of caregivers are motivated for a reason. Healthcare systems are going to be motivated for a reason too. Entirely different. Heart and money, but you got to deal with them both. And with the healthcare systems, you do have support in your community, as the Alzheimer's Association has health system liaisons, and Matthew or someone may help me with the correct term, but these individuals are really experts in understanding how to make relationships with the healthcare systems. As I said, they're supported by the Alzheimer's Association. They tend to cross across chapters, so you don't have to necessarily worry about whose chapter, but they are placed all across the United States and are making a big difference in getting healthcare systems to adopt evidence-based programs. So find out those people and go to them, and they can help you be introduced to the right persons. Two quick other topics here. And how do you get attention from a healthcare system? For not-for-profit systems, have to have something called a community benefit. Some of you know that it is based upon a community health survey or a community needs survey. So every hospital that is a not-for-profit hospital, we're not paying taxes, so we should return something to the community is the theme. Should do a community needs assessment, and then have a plan that addresses that. I have tried for several years to get my health system to do more around dementia and caregiving without a lot of luck until 2 years ago. And we have a large number of hospitals, but in about 5 of our community needs assessment, dementia, Alzheimer's disease, and caregiving popped up for the first time on our community needs assessment, and I got things done within 6 months. With working with the Alzheimer's Association and some other partners. So find that person, your community benefit person, and they will help you a lot. Lastly, people now give to aging. Try to make partnerships with your organizations to do some kind of joint health and wellness initiative. And Marcia, I'm going to end with this. In Marcia's hometown of College Station, we're building a new health and wellness center that is largely funded by private philanthropy.
Terrific. Thank you. What I liked about Alan's talk is one, the call to have prevention be broader, but then it's that quote, hit yourself to a wagon. Don't think you can do this alone, but basically think of the multiplicative effects that you can have. So now we have some time. I don't see any people coming up to the microphones, but I have a question to get us started. We started talking about sort of with Janet Wright about health, sort of heart health. And so the question to ask the panel is, how can partnerships, coalitions work together to bring more attention to the value of cross-disease activities? We're here to talk about dementia, but we see all the relationships with other chronic conditions. And I know there are a lot of people in the audience that do chronic disease. So can we just have some short reflections on that? Janet, you want to start?
Sure. Well, maybe an example. I can tell you that in the early days of Million Hearts, because it was about preventing heart disease and stroke, heart attacks and stroke, we actually spent a fair amount of time trying to figure out, should it be Million Hearts and Brains? That got a little graphic. Should it be Million Hearts and Minds? But that didn't convey as much of the dementia focus as we wanted, and we weren't sure about the evidence in the first 5 years. In the second 5 years of Million Hearts, we knew by then, thank goodness, because of work done at CDC by perhaps many of you and certainly our colleagues at NINDS, that midlife hypertension contributes mightily to dementia in later years. So we again revisited the name and went through a whole lot. What we ended up committing to was highlighting in as many ways as we could as this connection to dementia. So we were more in the lane of awareness raising. I will say now, through the funding that our division is putting out to states and local health departments, we're incredibly focused on equitable detection and control of hypertension, and always try to call out not just the fact that it will impact heart disease and stroke, but also dementia.
Thank you. Would somebody else like to comment on multiple diseases and multiplication?
Sure, so I can. We have in Mississippi something called the Mind Center. It's the academic research center that addresses a lot of our Alzheimer's disease and related dementias. And when we received the BOLD funding, one of the initial questions was, how do we motivate a very workforce short area in addressing these comorbidities? And that's where we started, because we knew that one particular entity, for instance, our cardiovascular friends, I'll say, were also experiencing workforce shortages. And so it was easier to look at the risk factors and address them collectively than individually and independently.
Thank you. Let's have one other comment, and then I see some people at the microphone.
So my partners, Sarah, and Seth with the Nevada Division of Public and Behavioral Health have really been leading the way to create more synergistic connections. And even when we launched Dementia Friendly Nevada, I have to admit this is part of that vulnerability and authenticity that I had tried recruiting public health professionals to Dementia Friendly Nevada and was not very successful. And so I'm grateful for our BOLD funding and the Nevada Division of Public and Behavioral Health's work on this issue, and really bringing partners representing different chronic conditions to the table to have shared conversations about risk reduction and health equity. I don't know why we have constructed our silos when we have so much in common, and I do think that health equity is a really important unifying theme.
Thank you so much. So when you get ready to speak, please give your name and your affiliation. So let's hear from our first audience speaker.
Hi. Ooh, sorry. Daphne Delgado. I'm with Us Against Alzheimer's. We're an HBIB grantee, so we focus on Latino and Black communities for our grant. So I have two questions. The first question is on that health equity issue. What are some specific strategies that you guys have employed, especially when you're putting up coalitions in different parts of your state, to really kind of specifically reach the communities that are intended to be reached? And then,
Well, let's ask one question at a time, because
Okay.
otherwise they're going to forget.
Okay.
Who wants to address the first question? Health equity. How about Kenya and then Alan?
Sure. So we actually work with Daphne and the team, but when we started our health equity ambassadors to create sort of a unifying theme of understanding, we really focus heavily on the training. So cultural competency training, implicit biases. So one of the very first things I would do is have a concise definition of how each of you are defining health equity, because you'd be surprised how many have a differing of opinion of exactly what health equity and addressing health disparities means relevant to the work.
Excellent. So another panel comment?
A couple of things that related to healthcare, I think, is the importance of understanding social determinants of health and when those should be assessed and how they need to be assessed differently among different populations. I know in our system where we have had to scale back on some of the assessments around social determinants of health in clinics that were especially designed to reach underinsured and uninsured, because it was devastating to hear those assessments come back. You know, I mean, it was upsetting how desperate people were for meals, that the staff was traumatized by the need. So those clinics had to pivot to say, we don't assess, we just assume, you know, and build out what you needed around the wraparound services. So that's how, I'm not saying that's a great model. I'm just saying that was kind of the reality we got shocked into. So not a really good answer. But the All of Us research program has a real strong focus on making sure that that populations that have been underrepresented in previous biomedical research are more appropriately represented. Really, I think right now about 70% of the sample falls into one of the UBR categories. So something to look forward to in the future of having a better data set that is more representative.
Thank you. We're going to go to the other microphone first because we want to give everybody a chance. Can you introduce yourself and where you're from, please?
Yes, my name is Teresa Will. I'm the administrator of a small public health unit in North Dakota, City County Health District. And we are an HBI grantee and working within our community. We work closely with our critical access hospital on the community health needs assessment. And dementia or Alzheimer's concerns were quite a bit lower than a lot of the other things, substance use and mental health and such. Were there any specific questions that you added to your community health survey, or that they added, I guess, that got you there?
I'm not familiar with the exact question, so I don't think it was anything new as much as it was the rank ordering, and also the aging of the specific communities. So I will say in the communities in which those topics became more frequently cited were more heavily white, Caucasian, middle to upper middle class. You know, so you're starting to see the same what we earlier about the difference of the equity of issue, is that some of the other issues like opioid addiction or food insecurity, maybe those dominate some communities more so than aging. But it is interesting to see how the what shows up on a health needs on a community needs assessment is influenced by the socioeconomic distribution of the area. So again, not defending anything, just that's kind of the reality of what we've seen.
Thank you. Let me sort of follow up with that because people talked in the early sessions about data. So the question to ask the panel is, what data or tools are needed to make partnerships and coalitions more successful? So what kind of data would you like to have and that you're generating? Jennifer, it sounds like you have something to say.
You see it. I think that successful partnerships and coalitions really, focus on the process and not on the outcome. And so I think helpful tools for coalitions, wait, let me just back up. The outcomes are important, absolutely. But if you're not focusing on the quality of your partnership first, then you'll never achieve the best outcomes. So there's a connection there. And so I think some tools and resources that would be helpful are things like authentic partnerships questions, where we take the moment, pause periodically to talk as a group about how is this going? Are there things that I could do to better support your contributions? Because we need your knowledge and experiences to be part of the solution. And in terms of data, I'll just briefly say that I believe that data, it's important, but really it should be used to help shape meaningful conversations with community members about issues of immediate significance and importance to them. And so it's really, for me, it's not about the data, it's about the dialogue about the data.
Thank you. Any other comment before we go back? Did anybody else want to say anything about data or tools?
So I'll just share quickly. I also, while I do agree that the dialogue is very important, oftentimes you have to have the data to start the dialogue.
Yeah.
You have to have a starting point. The data that we were missing in Mississippi was data on older adults at the community level. So very recently, through a partnership with Massachusetts, our state now has, for the first time ever, county level data profiles for older adults in Mississippi for all 82 counties. So now we're having those engaging conversations about healthy aging. What is missing? We have a number of critical access facilities that will soon close just due to a number of issues in our state. So the data begins the conversation, but that shouldn't only be where you start.
Thank you so much. Let's hear from the audience again.
I'm a little short for this, sorry. I'm Elizabeth Anderson Hoagland. I'm from the Kentucky Department for Public Health and Health Promotion. And I love that so many coalitions were able to include people living with dementia. How do you go about recruiting people to participate in that? And how do you keep the engagement meaningful?
Thank you. Who wants to tackle that one? Beth?
Well, while this specific example that I spoke about was not so much of a broad coalition as some of these examples, some of what we've worked on afterward in our continuing efforts has been more in that format. We do have a state Alzheimer's Resource Coordination Center. It's one staff person in our Department on Aging, recently funded. We have an advisory council for that, which includes numerous stakeholders, all that to say, including individuals who are living with Alzheimer's or another dementia. And so when it came time to make sure that the governor's appointments were current, that we were representing all viewpoints, I think one of the things that you've got to do is look to organizations, particularly those who are working with the Alzheimer's and dementia population, to say, hey, who do you know? Because even we have difficulty reaching individuals who have been diagnosed. Many people are very just focused on living their lives, living with dignity, do not necessarily feel the pull to step up and become a champion. But many simply have not yet had the invitation to participate in this part of the process. So definitely look to the organizations in your community who might be working most closely with those individuals, because they have a lot of very valuable perspectives to bring to the table to help inform the way that we're approaching these issues.
Thank you. Does anybody else want to comment, or do we want to go to see what our next two questions are?
The only thing I'll add is support groups. We have some very robust caregiver support groups in our state, and you can also reach out to your support groups to identify individuals with a lived experience.
Just briefly, I think that it's important that we work hard to break the stigma of dementia. And that is one reason why it's hard to recruit people living with dementia, even in Nevada, where it's one of our core values. And so we have given that challenge a lot of thought, and we have developed stigma-busting opportunities that are freely available to anyone, anywhere living with dementia, but twice a week, for instance. It's just one example, but twice a week we offer an online program called Dementia Conversations. On Mondays is with Chuck and Jennifer. Chuck McClatchy has been living well with Alzheimer's disease for 8 years. He facilitates the discussion with me as a family care partner. My dad is living well with dementia in Washington State. And on Fridays, it's Dementia Conversations with Nancy and Kat. Nancy Nelson, another incredible self-advocate living with mild cognitive impairment. And I'm sorry, Nancy Nelson living with MCI, and Kat Hartley, who is like me, both a professional and family care partner, plays the role of a family care partner. And these conversations, it's not a support group. It's education. It's supportive education. And I think because these groups are led by people living with dementia, it creates a safe space where other people can come and share their experiences and then connect with a supportive community that supports self-advocacy.
Thank you so much. Let's go to one of our questions.
Marcia, can I
Oh, yes.
just
Okay.
quickly jump in and say, it's so important, everything that's being said, but I've got to say, one of the biggest barriers, at least in Texas, is early diagnosis, where we tend not to get people the services they need, individuals who are experiencing it, early enough for them to be diagnosed and for them to make their own decisions about contributing to being a part of these things. So early diagnosis is a key to having more engagement.
Really important point. Let's hear our next question.
Thanks. Hi, my name is Kelly O'Brien. I'm with Us Against Alzheimer's. Really engaging conversation. So grateful to have you all with us today. Just a brief question. We're talking a lot about the kind of coalition development that you all are doing. And a couple of you have mentioned the difficulty of getting others to join your coalition, or having other issues being important in the community, like in the community assessment, having nutrition be a top issue. Have you joined other organizations? Have you joined the diabetes coalitions? Are you working with the nutrition groups? Are you, instead of asking people to come to you? Because it is striking to me that if nutrition is a top issue, for example, in your community, helping people advance that goal is fighting dementia. And so I'm wondering how much you've had success participating in other coalitions and groups.
Thank you. Let's hear one or two examples.
I'm a big believer in United Way and being engaged in United Way, because it's an entirely different group of people at the table in United Way. So I think it's another way of kind of reaching out to different groups. I can also say, if I can be a bit of an advocate here on a personal level, United Way needs to be pushed to be more aging sensitive about their programming. So I think it's a way for us to both advocate for greater services around for aging in general, but also to make those connections to other groups. And United Ways also will put together, we did a lot of work in Tarrant County Texas, and putting together various organizations and through the community that included Easter seals and Meals on Wheels, the American Heart Association. So there are opportunities to do some cross-cutting work.
And I think what's important is to think about coalitions that you might not normally think about. So other examples?
Sure. So one coalition that many may not think is relevant, but is our Interagency Transportation Committee. With our Department of Transportation, through the work I was doing with Age-Friendly Public Health, I was invited to sit on the Transportation Committee. How many people talk about loved ones not being able to get to their facility for care because of a lack of transportation? So I think even outside of the clinical space, there are some non-traditional partners that are extremely helpful in this space. And just being creative and innovative is definitely a great way.
That goes to my idea about health in all policies and programs. Let's hear from our next
Hi, everybody. I'm Julie Knight. I'm with the Louisiana Office of Public Health. We're a Bold Grant recipient. This is kind of piggybacking Dr. Stevens in his presentation. And also I'm calling out Keena White and Beth, if you could answer to this. But about health systems and collaborations, Louisiana has recently made those connections with the association for their health systems director to bring about a collaboration among Project ECHO. But my question is, I want to see what's going on in Mississippi and South Carolina to understand how you're working with health systems and how it relates to your coalition.
So let's hear from those two states.
I will say it's definitely a work in progress. Navigating health systems is, it's a whole new map for us. And so the Alzheimer's Association a few years ago established this very intentional initiative to build into those infrastructures and find the right people to talk to about what's going to make the most impact in those health systems. Unfortunately, I'm not that person in my state, and so I don't have as much of a detailed example, I think, to give you as what you're looking for. But I am really excited to see the momentum and hear what's going on in other states because, much like we work with government for public policy, our health systems are kind of our private policy, right? It's still a system that we have to learn to navigate and make sure that the right conversations are happening at the right point. I can tell you that in South Carolina, we are just beginning to work on provider outreach, whether that's going directly to primary care physicians or trying to work through those health systems, because we, like Mississippi, have that provider shortage. Our neurologists, our geriatricians, pretty much all across the workforce, we do not have enough specialists to serve the population that we have facing dementia. And so we have to really look at those front lines, the primary care physicians, and figure out how we can get them the resources they need to point to the next step, even if they can't provide it directly in their office. All that to say, I would also like to know more about that because there's so much work to do still in that field.
And the good news is I think we're going to have a whole session on health systems later during the conference. But let's go to you, and then we're going to have a wrap up, okay?
Hi, Tiffany Robb from Idaho. Going back to building your coalitions, I feel like in Idaho, because our Alzheimer's disease and related dementias program that is embedded in public health is so new, I feel like we're kind of cooking pasta, throwing it at the wall to see what's going to stick. And so what I love to hear from you, thinking upstream as public health we should do, what are some strategies or organizations or maybe youth-focused organizations you've really focused on to try to bring to the table when we think about brain health across the lifespan?
This sounds like a lunch discussion, but we're going to have some short answers. Okay, Kenya, would you like to join?
Sure. So real quick, Tiffany, intergenerational programming, we work closely with 4-H Extension. with extension services. So I definitely think intergenerational programming is a great way to bring youth into the conversation. And then also, earlier it was mentioned about traumatic brain injury, but we do a lot of work with helmets and safe routes to school and talking about protecting your head and bicycle and things like that. That's another way to bring youth into the conversation, just to talk about brain health from a life course perspective. Just really quickly, the question about health systems, we can definitely, Julie, talk, but in Mississippi, a couple of ways that we've worked with health systems. So we look at our lifestyle management programs like A Matter of Balance and others and embedding those within health systems. But also I'm a former health systems administrator before public health. So working with your hospital association, we actually work very closely with a lot of our health systems and have our community directors sit with them and understanding their community health needs assessment data, because a lot of our health systems are not conducting their own assessments. They're hiring consultants. And so what happens is they don't understand the findings. They're just checking off a box that they completed the assessment. But what we're doing is actually educating the health systems on interpreting their data and prioritizing how they spend their community benefit dollars. And even if Alzheimer's and dementia does not rise high as a priority, those shared risk factors, I'm almost positive hypertension or diabetes will be on that list. And if you're addressing those risk factors, you're also addressing the others.
Thank you so much. So we're going to wrap up by giving each panelist up to 30 seconds to sort of tell us their take-home message. And if it gets to be too long, I'm going to stand up behind you. So you're first. Short, pithy. What do you want the audience to know?
You have a big job ahead of you. It's going to take more than a village to do it. And I would ask you to fuel yourselves with the small successes that you will generate, because you're in it for the long term. I'm seeing if Dan is still here. You're in it for a marathon. So pace yourselves, but celebrate along the way.
Excellent. So next.
Citizens can change the world. Indeed, it is the only thing that ever has. And the truth is that coalition work is hard and it is messy. And if you're really committed to collaboration, it is completely unpredictable. At times, it's even frustrating, but ultimately, and I really believe this, it produces better outcomes than anything a single expert or even a team of experts could produce alone. You know, coalitions produce positive, high impact, sustainable outcomes.
Thank you. Next.
Simple. Never be afraid to serve. Even if you think that it may not be of benefit to you, it is. And that's something that we've learned. Someone asked about how do you support other coalitions? You serve. The same way that you ask for representation for your work, be willing to serve for them, because that's where conversations begin and that's where people begin to trust you, when you're willing to serve with them just as much as you're asking them to serve with you.
I would say don't be afraid to start somewhere, start a conversation, and look for those natural allies. Look for where your missions align. I think you'll be surprised who's already out there who would be really excited to hear from you and start talking about what we can do together.
Be very mindful of the need for clear communication and understanding across different groups. There may be a need for translation, not by the language, but by the terms that are used. And that sometimes I'm afraid in our coalitions, we break down because we go to our separate corners without understanding what we're saying. And more often we're more in common than we're separate, but we're talking different languages.
Thank you. Let's give our panelists a standing ovation.